Welcome to week 6 of mental health. This week we are going to be talking about ethics and health law, so some professional practice concepts, and then psychiatric health law and ethics. A lot of this will be a review, not a lot, some of this will be a review from your funds class. We talked about a lot of these things. All right, so we do have varying amounts of laws that govern who can be admitted to the hospital, when they can leave on their own, when they cannot leave on their own. There's a lot of variability with that. So because of all the issues, they do have certain laws that kind of explain a lot of key points. So when you think of someone who needs to be admitted for any type of mental health illness, they could either come in on their own. So it could be voluntary. They recognize that they have a feeling, that they recognize that they have an issue. They don't like the way that they're feeling. They want to participate in getting better. So they're willing to seek treatment and they agree to be hospitalized and do whatever the recommendations are. The other type of admission status that we see is involuntary. So these are people that do not want to be hospitalized. They don't want to be treated. They may or may not agree that they have an issue. So it is against, it's not on their own terms. We're going to talk about the laws that govern discharge. So if a person is admitted or if they voluntarily seek treatment, when can they leave? We're going to talk about ethical treatment of psychiatric patients and then some self-advocacy for patients and their family members. So usually this is, this obviously can vary from facility to facility, but basically in the hospital settings, we see that the current admission process is that a patient suffering with some type of mental illness will come in through the emergency room. They will come in on their own. They might have a family member, a loved one that brings them. They might have just even a friend that accompanies them if they don't have any family they can depend on, or they could be referred from another facility. Or someone could have went and filled out an emergency petition to have them admitted to be treated. So this is an emergency petition, is a document that is filled out by a witness. It does give the police the authority to take the person to the emergency department. Once the person arrives at the emergency department, they get a mental health evaluation. It doesn't mean at that point that they will definitely be admitted. It just depends on the outcome of the evaluation. Whether or not this patient is a danger to themselves or to anybody else is going to be a big factor in whether or not this person is actually going to be admitted or if they're going to be discharged home. Because we know if they're a danger to themselves or others, then we don't want to just put them back in the community where they could get hurt or they could hurt someone else. So with a voluntary admission, like we said, the patient agrees to the admission. They recognize that they have an issue. They recognize that they need to seek treatment. They are more likely to actively participate in their treatment to get better if it's something that they agree on and that they understand. When you come in under a voluntary admission, you may leave your emergency department against the medical advice. So against medical advice, or AMA is how we say it in the clinical setting. This is when the doctors will say, Mrs. Jones, X, Y, and Z is occurring right now. We don't recommend that you leave. If you do, it could be detrimental to your health. We think you should stay here and engage in treatment. The only time that they would not be allowed to leave on their own is if they are considered to be a danger to themselves or others. So this is what the voluntary admission um, outline looks like. So at the top, they come in on their own. They're either going to have a regular discharge home because they're not a danger to themselves or other, and they're capable of meeting their basic needs, or they say that they want to go home. They have to give a 3-day notice. So they have to give a notice that they want to go home within 3 days. You have to discuss with the patient the reasons for wanting to leave, and then you have to give the form to a patient to complete. After the evaluation, they can either be discharged, they can rescind their notice and decide to get treatment, or the psychiatrist who's evaluating them can convert the status to an involuntary. If they are not discharged and they rescind their notice on their own and they say, never mind, I don't want to leave, I want to stay and get the treatment, they'll get their treatment and then they'll be discharged. Or if they are converted to an involuntary status by a psychiatrist, then there's a whole nother grid that they would follow for the involuntary status, and we'll talk about that. So during the 72-hour hold, that 3-day period, a patient may formally request discharge by submitting that 3-day notice. The psychiatrist must be notified. The treatment team will meet together. Each of them will give their input, and they will decide whether or not that patient is safe and stable to be discharged. They may talk to the patient and may convince the patient to stay, and in this case, they will remain voluntary. If at this point the patient is found to be unsafe or a danger to themselves or others, that's when the status would be changed to involuntary, which means they could not leave on their own. So in order to have someone converted to an involuntary admission status, it has to go through a certification process. It requires 2 medical doctors, or 1 medical doctor and 1 PhD psychologist, or a psychiatric nurse practitioner. So you can't just have one person say that this person is a danger to themselves or others, I'm making them stay here, they can't leave. It does have to be 2 people for good reason. They must be a danger to themselves and or dangerous to other, or they must be unable to care for themselves. Being unable to care for themselves is not a criteria in Maryland at the present time. It is something that Maryland is looking at, but right now it's not a criteria. And then they have to meet the 6 criteria for commitment, which we're going to talk about. So in Maryland, for commitment, the person must have a mental disorder. So they must be diagnosed with a mental disorder. They must require inpatient treatment. The person must be a danger to life or safety of self or others. The person is either unable or unwilling to be admitted voluntarily. And there is no other less restrictive safe treatment. So this is the only option left for the patient. And if you're 65 or older, you must be evaluated by a geriatric evaluation team for the least restrictive environment. So that's the 6 criteria for the state of Maryland. So if a patient is certified or committed, you'll hear those terms interchangeably. They do not agree to hospitalization. They do not think that treatment is needed. They often are resistant to treatment. It is against that patient's will or what they believe in. Or what they wish for themselves. They still retain all civil rights that are afforded to all people, except the right to leave the hospital in the case of involuntary commitment. So this is an ethical issue for some people. How can we treat people without their permission? And how can we protect individuals and society? So just something for you guys to think about. If the patient is going to be kept involuntarily, we have to have an NOH, which is a notice of a hearing. It is a legal document that you must have 1 original copy given to the patient within 12 hours. That piece of paper that you give them is going to tell the date of the hearing for their state. It's going to notify the patient of the date of the hearing. It is mandatory that this hearing be held within 10 calendar days. And what happens is each hospital has 1 hearing day a week. So that way they're able to meet the needs of all their patients. Nurse responsibility for this notice of hearing, we are to ensure that all the information on the notice of hearing is correct. We want to give the notice of hearing to that patient, let them know what it means. And then if need be, we could also accompany the patient to the hearing. The purpose of that hearing is to determine if the patient should remain in the hospital against his or her will. So just because we have found that they are a danger to themselves or others, it's kind of like when we use our restraints. We use the least restrictive for the least amount of time. So this is not something that we want to keep going as long as possible. We want there to be an end in sight. So we're going to have this hearing. We're going to determine if it's still acceptable for this patient to remain against the hospital against his or her own will. There will be a judge present. It is a legal proceeding, and then they will be sworn in for testimony. So the people that usually come to this hearing, it's going to be the administrative law judge. It'll be one from the state of Maryland. There's going to be a public defender. The goal is their goal is to work for the patient and to obviously get the patient released as soon as possible. There's going to be different members from the treatment team that have been taking care of the patient. You could see family and friends there, and then of course, obviously, the patient will be there. So what could the outcomes be of that hearing? Well, the patient could be found that they're still dangerous to themselves or others, and they can be retained, still committed involuntarily. The patient may appeal that decision within 30 days one time. If he appeals it, there will be another hearing scheduled. If they're released, it's obviously that the people involved have deemed the patient not dangerous. At this point, there is some paperwork that needs to be done. Not that some paperwork needs to be done. Sometimes that the patient could still be dangerous, but maybe the paperwork hasn't been done correctly. And if you don't fill out the paperwork correctly, then there's really nothing you can do. You have to let the patient go at that point. Or the public defender will go in front of the judge and plead his case for his client, and they may win the case and the patient may be released. Or the patient agrees to switch to voluntary status before the hearing. That's always a good thing. And then the hearing can just be canceled at that point. So if they are retained as involuntary, like we said, they can appeal within 30 days. They're going to have another hearing scheduled. So we're going to give them another notice of hearing with all that information. Another decision is going to be made whether the patient is still involuntary or if they may be released. If the patient is retained as involuntary a second time, now it's going to be on a more long-term involuntary hospitalization. So if this happens a second time, there really is an underlying unsafe mental issue with your patient that really needs to be addressed. They still, even though they're involuntary and we are holding them against their will, they still can refuse medication throughout this entire process. Like I said before, they retain all their civil rights that are afforded to all people, except the right to leave the hospital in the case of involuntary commitment. When we talk about medicating a patient against their own will, so we do this sometimes. We do it in an emergency, and it allows us to give a one-time PRN dose to reduce aggression in patients. Scheduled medications may be refused by the patient, whether they're voluntary or involuntary. And if they need their medications and they are refusing them, then we would have to have another hearing for that. It would be a medication hearing. Usually what I see in my facility is if we have to get a one-time PRN dose, it's usually an IM dose. It takes a couple of us to actually hold down the patient, and we have to get a physical hold order put in by the doctor that gives us permission to physically hold down the patient to give them the dose. So if they go for a med panel hearing, we're going to give them another NOH, that notice of hearing paperwork. At this hearing, now these patients have to be declared involuntary first. Now they're going to determine whether the patient will be forced to take medications. Also, the patient may appeal this again, ×1. If so ruled, immediately after the hearing, the patient is given with medication it often begins that any medications that we have to give them are given by IM, because if they're refusing to take them, just because the judge says that they need to, doesn't mean that they're going to start swallowing pills. And hopefully, as time goes on, if we can get their meds straight and they can participate with some therapy, the goal is that they would be moving in the right direction, feeling better, and that they could soon transition to PO medication. So this is what that involuntary admission looks like. Again, they brought in involuntarily. They're going to have a court hearing. The court hearing is going to be a judicial discharge, so the patient will go home, or the patient is committed involuntarily. If they are involuntarily treated, kept, then eventually they'll be treated, they'll be converted to voluntary and then discharged, or it's going to continue with that involuntary status. They're going to refuse their medication. We're going to have a judicial forced medication implementation. We're going to wait and see if the patient improves. If no improvement, again, more of that judicial enforced medication, and hopefully they will be treated and converted to voluntary and then discharged. So I'm sure most of you guys have heard in the news at some point in your life that someone has done something and they're claiming the insanity defense. So the insanity defense means that the person who committed a crime, that they're not criminally responsive or not guilty by reason of insanity. So this, when you have a patient who is saying that they are insane or they are not criminally responsible for their for whatever crime that they have committed, usually what will happen is they don't actually get they're not given a defined sentence. So they might not get the death penalty. They might just go somewhere and receive treatment. They might have court-ordered medications, and then somewhere down the line, they're going to have that conditional release. Insanity defense has legal meaning, but no medical definition. Patients are determined incompetent to stand trial due to mental illness, and they have to be evaluated by a psychiatrist. They just can't say that they are. So a court has to deem that they are unable and incompetent to stand trial. A person who is unable to control his or her actions or understand the difference between right and wrong at the time of crime. This is someone who would use the insanity defense. So there is something called the Manhattan Rule. So this insanity defense was originally first used in 1843 in England by a person by the name of Daniel McNaughton. He actually killed the prime minister's secretary mistakenly. He mistaked him for the prime minister, and under an insane belief that the government was persecuting him. He was tried and acquitted on the ground of insanity and committed to Bethlehem Hospital. Now, sometimes these patients will stay there forever. Some patients never leave these homes. Some patients, you'll see that after years of treatment, that they are released back into society again. The public's perception is usually that the person accused of the crime gets off and they're free immediately, and that's really just not the way that it is. And insanity defenses are actually very rare. We hear about them in the news and on TV, but it's really, they only account for 1% of all felonies. The defense can only be used when the person meets the criteria for an insanity defense. And there are 3 states currently right now that do not allow the insanity defense, and that is Montana, Idaho, and Utah. So if the patient is admitted voluntarily or involuntarily, the patient is going to be brought to the inpatient unit where they will be staying for the duration of their admission. When they get there, they are forced to take off all of their clothes. All of their belongings are searched and taken out of the room and stored until they're ready to go. They do an admission database that needs to be completed. All of the patient's admission orders are going to be obtained from the doctor. And then at first, they're going to be on what we call close observations or 15-minute checks. And then gradually, as they go on, it's going to get longer and longer in between those checks. Like we said a couple of slides back, patients do have the certain rights during this whole psychiatric hospitalization. They have the right to receive telephone calls. There is usually, most units have a phone specifically for patients to use. They are allowed visitors during what they call published visiting hours, unless the patient or the visitors are disruptive. They're allowed to vote. They can receive and send unopened mail. They can have visits from their lawyer, their interpreter, their patient advocate, and any clergy member. Their treatment rights. So, of course, they are still patients. They do have a mental illness. They do have rights. So they have the right to be treated at an appropriate level of care in the least restrictive environment. They have the opportunity and the right to participate in the planning of their own treatment. If we engage them and we listen to what they have to say and they help us plan their treatment plan, they will most likely be more engaged and be more willing to participate in the treatment. They have the right to give their informed consent, and they have the right to know their diagnosis. So the right to treatment, O'Connor versus Donaldson from 1975. This was about an individual that is not posing a danger to herself or others and is being capable of living without state supervision. The state has no right to commit the individual to a facility against his or her own will. So that's where that came from in 1975. And then the patient must be active. It must be active treatment, not custodial. So we know that custodial care is care that is primarily for assisting the individuals in any activities that they do for their daily living or meeting their personal needs rather than their medical needs. So these are patients who at baseline have issues that live in the community. This is more like an acute exacerbation issue, not just an ongoing regular issue. So patient treatment rights, we all know about HIPAA. We have to be confidential, more so, especially in this environment. So we never want to talk about if famous people come on the unit, if any employees are there, if it's anyone that you know. Only the treatment team should have access to the record, whether it's electronic or written. So if you're not caring for that patient, you should not be within that chart. You never, ever, ever want to take a picture of any of the patients that are there. You don't want to talk about these patients on the elevators, in public restrooms, and things like that with your family members. You want to leave your information at work. So we did discuss that there is an exception to confidentiality, and that is the duty to warn. So this is when a patient makes a threat against a specific person. The treatment team must notify the person that they are threatening to hurt. Obviously, we don't want that anything terrible to happen to that person. So that is the only time that we will breach that confidentiality with our patients. When we talk in the aspect of patients being competent, so we view competency as being able to make informed decisions. To be declared incompetent, like we said, 2 doctors must evaluate that there is actually an incompetency that exists. Incompetent is a legal term that indicates that the patient is unable to manage his or her life or their own affairs. So then they can no longer enter into any type of legal contracts, they can't vote, or they can't drive. If they're incompetent, they must have a guardian decision maker that has to be appointed to be able to make decisions for them. It is very rare that you see that a patient is incompetent. We do see it in cases where maybe there could be some intellectual disability, some mental retardation if they've suffered some type of brain damage, or if they have some type of dementia. And then sometimes it could be seen just on a temporary basis if the patients are under the influence of some type of a sedation or anesthesia. So nursing inventions, so obviously we are going to base all of our nursing inventions on the right to the least restrictive environment. We want to be able to help the person to regain behavior control when a person is dangerous to themselves or others, when the patient's behaviors are disruptive in the milieu. All of these interventions that we would do are going to require doctor orders. So we could have zoning. So zoning is where we keep certain patients in certain areas with a nurse or two in that area, like they have certain bays and they would maybe have 2 or 3 patients here with 2 nurses, 2 or 3 patients over here with 2 nurses. That's what we call zoning. Each staff member would be assigned to a certain zone. Be in staff eyesight. So obviously we, in these milieus, we don't usually just let these patients run around unsupervised because we know there's the possibility that something could happen and there could be an outburst and then it could lead to a fight. Sometimes we need to be one-to-one with patients because they're disruptive and they just are not allowed to, for the safety of others, to be around anybody else. So we would have to sit with them one-on-one. We could do what's called close observation. So this is where we have a bay that would have maybe 3 or 4 beds, and you could have 3 or 4 people that all needed to be considered close obs, which means that they don't have to be one-on-one, but they have to be watched closely. So we would put 3 or 4 of them in one bay, and then one person would sit in the hallway and watch them. And then, of course, we know that we could have to use chemical restraints, which are medications, in order to control our patients. We have physical and mechanical restraints. Rarely are these used in psychiatric units. We use these primarily when the patient is going to be harmful to themselves. If we do have to use any type of restraints, it is recommended they come out of their restraints every 2 hours, and we assess their need to continue in the restraints. So are they calmer now? Are they still being a harm to themselves or trying to hit the staff? If they are, they're going to go back in the restraints. When we take off the restraints, we're going to offer hydration. Do you want something to drink? Do you have to go to the restroom? Would you like to have anything to eat? We want to do good range of motion, move their legs, move their arms. And then we also need to do really good skin checks wherever those restraints are applied, because depending on how upset the patient is, even though the restraints are keeping them from having total movement, it could be moving on their arm and rubbing and causing a red spot or an open area. So the types of restraints that we see, we have mittens that look just like that. They're mittens and they Velcro around the wrist. Patients can still get out of them and they can still pull tubes out with them. We have wrist and leg restraints. We have 2-point and 4-point. We have jerry chairs that we can put them in that kind of have like a black belt that keeps them from coming out of the chair. And then they have something called a papoose, which I've actually never seen in my hospital. You would probably see this maybe in a mental, like just a facility for the mentally ill. Then we always have, if available where you work, they have seclusion. So if you were going to put someone in seclusion, it would have to be a last ditch effort. So you would want to use all other alternatives possible first. So this is going to be your last option, and only when they are imminently harmful to others. You would need to have if you put your patient in seclusion, you could do it. If something was happening and there was, the patient was at danger of really hurting someone else, you could initially do it, but then you have to get that physician order. You have to give any PRN medication. So you have to have tried other things first. It can only be a very short duration, no more than 4 hours. And they have to be monitored continually for the first hour. So every 15 minutes for the first hour. No, I said that wrong. For the first hour, that person is sitting right there outside the door, continually monitoring, not leaving them at all. After that first hour, then it moves to every 15 minutes. Sorry about that. They're not allowed to have anything in the room except a mattress on the floor. The door that closes to the room they're in must have a window, and they must have a camera on the patient. Obviously, this could be a very dangerous situation, and this is not a situation where you would put a patient in that was suicidal. We don't want to leave them secluded by themselves. You would never have an order that was PRN or standing for a seclusion order. It would have to be something that you would get an order for after you implemented it. We have involuntary outpatient commitment. So this usually requires proof of a mental illness, and we have to be able to prove that they're dangerous. This is not available in all states, and it is not available in Maryland. It is a highly debated issue over individual rights and the need to protect society, and often is used after mentally ill offenders are released for jail. So sometimes if a patient's in jail, this is the example I'm going to use, they might release them under a conditional release that they commit to outpatient treatment on a regular basis, but they'll release them back into the community. Or they could be in a hospital setting, a mental hospital setting, and then they are expected to continue with treatment on an involuntary basis after the release of the hospital. So they still have to continue the treatment, but it's going to be outpatient. There is liability in psychiatric nursing, just like there is in regular nursing. So these are the things that are going to be kind of a review for you guys. So, when we talk about civil law, we talked about a tort. A tort is a civil wrong that is made against either a person, or it can also be property, and they can be intentional or unintentional. So intentional torts, psychiatric nurses can be liable for intentional torts or voluntary acts that result in harm to the patient. So examples of intentional torts, this is going to be your assault, your battery, and your false imprisonment. When we talk about your unintentional torts, that is going to be your negligence. So for intentional civil torts, your assault is going to be the intentional threat to bring about harmful or offensive contact. No actual contact is necessary. So an example of this would be a nurse telling the patient, if you don't take your medication now, I'm going to lock you in the seclusion room and you're not going to eat for 2 days. That is assault. You're threatening to be harmful. Battery is the intentional touching without consent, which may cause injury. So this is when the patient punches the patient. This is when the nurse punches the patient in the face because she didn't take her medicine. And then we have false imprisonment. So this is holding a patient against their will when we don't have reason to do so. So a nurse who threatens a patient or gives treatment without consent can be charged with what? We can talk about this in lecture. So our unintentional torts, this is where, this is negligence. So negligence is considered conduct that falls below the standards of care. So some examples of negligence include medication errors. So giving the wrong medication, giving the wrong dose, and then making IV errors, again, with medications that result in injury to the patient. Malpractice is a type of negligence that refers specifically to professionals. So this is negligence from doctors, physicians, physical therapy, speech pathologists, so those medical professionals. So in order for us to prevent liability, there are a couple steps that we can take. So we always want to remember to practice within the scope of laws, of state laws and our Nurse Practice Act. So remember we said before, if a patient started to decompensate and they needed to be intubated, that is not a skill that we do as a nurse. So we need to practice within our scope of practice. We want to collaborate with colleagues to determine the best course of action to make sure that what we're taking is agreed upon. Use established practice standards to guide your decisions and your actions. Always put the client's rights and welfare first. Develop effective interpersonal relationships with clients and families. And then accurately and thoroughly document all assessment data, treatments, interventions, and evaluations of the client's response to care. So that is extremely important. If you have an issue with your patient and their blood pressure and you had to hold a medication and you talk to the doctor, you want to document that. If you have a patient that is refusing turns and refusing to take medications, you want to document that. And if you're doing things for your patient, you want to document it, strict I's and O's, Q2 turns, things like that, because if it's not documented, it's not done. All right, so some ethical principles. So autonomy, we've talked about this before. So this is the independence and the ability to be self-directed. So patients do have choices available. We always want them to be informed of their choices, and we want them to be able to help participate in making decisions for themselves or make them. Involuntary commitment and forced medication must be absolutely justified in order to protect the patient. It has to be just the last resort for the greater good of the patient. But we have to remember that it is our ultimate job to protect the patient. And then we want to make sure that our patients understand their informed consent and the ability to understand exactly what they're signing for. If they're having a blood transfusion or they're having some type of surgery or they've agreed to take some type of medication. Beneficence is when we are promoting good. Our second duty is to prevent harm. And then our third duty is to remove evil or harm. We have non-malfeasance, which is the treatment that we are giving to the patient causing more harm than good. So this is where we have to look as nurses and say we are weighing the risks versus the benefits. I see this a lot in oncology patients because the treatments that we give cause so much harm. And then an example would be assuring that the restraints are not causing injury to the client. So these are all important. You're going to need to know these. So justice is making sure that all of our patients are able to have equal and fair treatment. And we also can think about the uninsured patients. So do patients that don't have insurance have the right to be treated? And they do. Everybody has the right to medical treatment. And usually there's, I think we talked about it in our fundamental class, that there is, that the emergency room, if you come in through the emergency room, that they will stabilize you until you are stable and out of the woods. That is their obligation. So then we have fidelity, which is being faithful to your promises. So if you tell your patient, I know it's important for you to be able to have a visit with your mom. Let me talk to the doctor and see if it's possible that, you're possibly ready to have a visit from your mom. Make sure you go and talk to the doctor in a timely manner. If you haven't been able to do it yet, or if you've tried but you haven't talked to the doctor, come back and tell them, I don't want you to think I've forgotten about you. I put in a call. I haven't talked to the doctor yet, but I am taking care of it for you. So be faithful to your promises. Veracity, being truthful, maintaining trust with your patient. So doing what you say you're going to do is going to maintain trust. And then show respect for your patient. Validate their feelings, practice empathy, respect them. And then, of course, always maintaining confidentiality. So we have to know that there is stigma with mental health, obviously. And we have to remember that our patients are not a diagnosis. Our patients are patients. They are humans with feelings. And diagnoses are not absolute. There's a lot of subjectivity that goes into diagnosing a person. Nursing diagnoses focus more on symptoms and needs. Psychiatric nurses have for years tailored their interventions to the symptoms that we are seeing. And then diagnosing patients in psychiatry is inexact, and it changes all the time. Nurses must maintain confidentiality at a very high level in psychiatric mental health settings. We never, ever, ever want to talk about the patient's names, any of the patient experiences, their jobs, what crimes they may have committed, or any other identifying information with anyone other than your clinical instructor your course instructor, or the treatment team. This includes your family, your friends, and your significant others. And then confidentiality standards are ultimately designed because we want to prevent discrimination and stigma for our patients. And then our standards of care. So we have the American Nurses Association Code of Ethics for Nurses, which states that we will practice with compassion and respect. Our primary commitment is to the patient. We promote nurses to be advocates to protect health, safety, and the rights of the patient. Nurses are responsible and accountable to collaborate with other healthcare professionals and maintain competence in their field of practice. And that is it for professional practice. If you guys have any questions about this, we will talk about this next Thursday when we are in lecture.